we are looking at the coronary artery disease CHD risk factors, and we have come to the final one, the markers. In the markers, we barely know these and test them. So these are the complex six. So ABPM is ambulatory blood pressure monitoring. Why this is important, ABPM? To know about the dippers and the non-dippers. Okay, flow mediated dilatation is another test. PCOS, polycystic ovarian syndrome, CIMT, carotid intima media thickness, FFEAZ, fluorescein fundus angiography, and STS, stress thallium scan for perfusion study. So these are the complex six which we generally do not do. So let us see what is the implication of these things. Let us start with the ABPM, dippers and non-dippers. There is a phenomenon called, if you look at the 24-hour blood pressure, a 24-hour clock time is there, 6 a.m., 8 a.m., 10 a.m., like that, midnight, 2 and 4 a.m. Our blood pressure normally dips in the night. As you can see, this is the daytime blood pressure, and as after 10 o'clock, it slowly comes by around 2 a.m. or so, it will be the lowest. This is called the dipping. This is for the systolic blood pressure. Same thing is true for the diastolic blood pressure also. What will happen? Some people, they don't dip. This is an indication of coronary artery disease, very, very early indication of coronary risk. So if you do an ABPM, so you look at this yellow line, this person, 140 and 138, not much of dipping in the night or day, it is almost the same blood pressure. It's not right. Normally the organs have to take rest during the night time, and at that time the pressure is supposed to be at the lowest, so that the recovery or recharging of all the organs will take place. This phenomenon is called dipping phenomenon. The earliest indication of coronary risk is absence of the dipping, also called the non-dipping. This is true both for systolic blood pressure as well as for the diastolic blood pressure. So look at the diastolic blood pressure. Normally it is around 80, and then it will come to around 70 or something like that in the night. Maybe daytime it may go up to 90, 95, but it dips nicely. This sort of dip can be seen. Whereas in non-dipper, the diastolic blood pressure is almost the same, around that 90, 85 like that. So the dipping and non-dipping is a very important parameter for us to think about the cardiometabolic risk even before the clinically evident risk behavior is seen. So second one is brachial flow mediated dilatation. BFMD or FMD, flow mediated dilatation. What is this flow mediated dilatation? Normally the blood is flowing in the arm, and we expect the flow to show a variation whenever we induce a dilatation in the blood pressure. In atherosclerotic disease, this flow mediated dilatation will be absent. This can be tested in your hospital also. We have this test. So you see, this is the baseline blood pressure cuff occlusion for 1 minute release. So we have put the blood pressure cuff and then applied it for 1 minute. At the end of 1 minute, brachial flow mediated vasodilatation we will see. Normally 3.1 millimeters is the internal thickness of the brachial artery. Post occlusion, it should dilate to 3.5. Okay, this is a normal phenomenon. If a person is not showing this post-occlusive dilatation, flow-mediated dilatation, that means there is a deficiency in the vasodilator mechanisms and the cardiometabolic risk is more. This flow-mediated dilatation can also be induced by injection of acetylcholine into that, and we expect the acetylcholine to decrease the vascular tone and produce a dilatation. This will be absent in people who have early coronary risk. The management of CHD, a smart test has come. What is that SMART test? All that we need to know is what evaluations we are doing. Age, sex, tobacco, family history, premature CAD, natural occupation, and the level of physical activity, height, weight, BMI, waist, blood pressure, pulse pressure, peripheral pulses, clinical left ventricular hypertension, ECG evidence, X-ray evidence of LVH. Echo is a better test. And then fasting PP, blood sugar, HbA1c for diabetes and pre-diabetes, fasting lipid profile, LPA once in a lifetime at least we have to do, HCRP, urine albumin, microalbuminuria, ABI, questioning for endothelial dysfunction, intermittent claudication. These are all the evaluations we have already discussed. Now, CHD risk scoring is there. What is the risk scoring? Framingham risk scoring, UKPDS risk scoring. United Kingdom Prevention of Diabetes Study, UKPD is a very landmark study, like that the PROCAM study, also the PhD study of the American Diabetic Association, Prevention of Heart Disease, PhD, which is the ADA study, and the Framingham study are very important studies which have given some risk models. What are the risk models? We need to know. The PROCAM algorithm. PROCAM algorithm, it is divided into point of score, divided into four quintiles: first quintile, second quintile, third quintile, fifth quintile, fourth quintile, five parts, 20 steps, 20%, 20%, quintiles. Independent variables in the PROCAM model are age, SBP, LDLC, HDLC, triglycerides, diabetes, smoking, family history. 525 patients of fatal and non-fatal myocardial infarctions have occurred in a study of 4818 men in 35 to 65 in 10 years. So they followed 4,900 people over 10 years, and 325 people have developed myocardial infarction. The risk was least in the first quintile and the highest 21% in the fifth quintile. So PROCAM algorithm very clearly states the higher the PROCAM risk score, the greater is the risk for coronary artery disease or myocardial infarction. Then T2DM risk estimation is there. HOMA calculator, Indian diabetic risk score developed by Mohan et al. In Chennai. This is called the IDRS, Indian Diabetes Risk Score, and HOMA calculator also are available. CHD prevention. Now, total lifestyle changes, TLC, medical nutrition therapy, and physical activity. So we call now as TLC, total lifestyle modification, total lifestyle change. Now, medical nutrition therapy, don't call it as diet earlier. Earlier, we used to call it as diet. We never call it as diet modification. We call it as medical nutritional therapy, because the word diet will be very scary. People will think that we'll ask them to stop everything and eat nothing. That is not what is meant by diet. So, medical nutritional therapy. Likewise, exercise is a very repulsive term. If you say you do exercise, people may not like it. You say physical activity. Oh, yeah. Physical activity I require. They understand. So MNT and PA and TLC are important. Now here is a small joke. What fits your busy schedule better? The doctor is asking the patient, exercising 1 hour per day or being dead 24 hours a day? Do you want to be like a vegetable dead body for 24 hours a day with all the diseases, bedridden, gasping for breath, always uncontrolled diabetes, sugar, and then blood pressure, and also having heart disease and not able to even walk 5 meters? Is better, or you can do exercise regularly 1 hour a day, which you have to choose, every one of us. So, when we say physical activity, what type of physical activity is important? Walking, jogging, preferably doing some aerobic exercises. Walking is the least that we recommend, because people who cannot really cope up with higher exercises, at least walking is important, but that is not adequate and sufficient. Better you do jogging and other aerobic exercises. How much? At least 45 minutes, preferably 60 minutes per day. How often? Every day you have to do. Every day, 45 to 60 minutes of physical activity, jogging and other things. What intensity? Heart rate must go up to 120 to 130 per minute. Okay. So what will be the target? Target heart rate should be around 120. Then only you are exercising. Otherwise, heart rate from 80, it goes to 85. It is not exercise. It is very simply you are wasting your time. So you have to have an intensity of at least 120 heart rate every day, 45 minutes to 1 hour, either jogging or other aerobic exercise. Answer is the health benefits of physical activity are proportionately related to the exercise volume. What is exercise volume? Exercise volume is duration of exercise into frequency in a week into intensity how you do. A woman will be there who is having osteoarthritis. She cannot do very intense exercise. She can do for about 15 minutes in one stretch like that, 4 times in a day, 1 hour into every day she can do. Another worker will be there, software engineer. He cannot do every day because of his work schedule. He can do 2 hours workout on Saturday and 2 hours on Sunday with high intensity workout. So people who cannot walk for longer durations, they can walk for 5 minutes to 10 minutes into 10 times in a day, which will be around 100 minutes. So either you can manipulate the duration or the frequency or the intensity, the net result is the same. So we have to insist that they must get at least enough amount of exercise as told above. 45 minutes to 1 hour a day, every day, without any gaps, jogging and heart rate going up to 120 to 130. Duration, frequency, and exercise. This we can call it as FIT. F is frequency, I is intensity, time duration T. The fitness depends on the fit. Fit is frequency, intensity, and duration. Okay. So, what is risk management? Intervention, dietary weight and counseling, uh, goals, optimum BMI should be maintained, decrease in the saturated fats, increase in the fruits and vegetables and fiber, diabetes management with its HbA1c less than 7%. Physical activity, improve physical fitness aimed for 30 minutes, 45 minutes to 1 hour a day on most of the days per week. Education of the patients and families, optimize the awareness of CHD risk factors. This is essential. Now, general principles of treatment. Sugar and carbohydrate to be replaced by complex carbohydrates. Complex carbohydrates means millets. Small grains will be there, no? The millets, not the rice and wheat and other things. The millets can be a complex carbohydrate. Their degradation time or digestion time will be more. Fiber should be an integral part. What type of foods they should take? For fiber, we all know. We have to advise. Saturated fat to be avoided. All green vegetables and all the whole grain containing foods, they have the fiber. For example, very white polished rice doesn't have much of fiber. If you have the coat around that, the red coat, that has got more fiber. Likewise, when you have wheat flour, don't take away the husk part of it and keep the flour without sieving. Have the wheat flour along with the husk associated with that. Saturated fats to be completely avoided. What are saturated fats? Ghee, vanaspati, and then hydrogenated oils. These are all saturated fats. Particularly for the shelf life, in the stores, they prepare any of these savories. They use what are called the trans fats. These trans fats will give a longer lifetime, a longer shelf life for the product. That's why they use the trans fats. Trans fats must be avoided. Do not reuse the boiled oil, because once you use oil, and it's a very costly thing to it nowadays, so they will try to put more oil and fry something and use the same oil again. This is what happens in the outside eateries and restaurants. They keep on boiling the oil, just adding another half liter every day and then using the same oil. This used oil is as good as a saturated fat because once you heat the oil to the boiling temperature, all the hydrogen bonds are saturated. It is no more an unsaturated fatty acid. It becomes saturated fatty fat, and it's not at all good. So do not reuse the oil. Grill, broil, bake, cook in water or microwave. Not deep fat fry. Do not eat deep fat fried foods. They look very tasty. But if in your homes, if you have deep frying pans, you donate it to somebody whom you don't like. Because deep fat fried items are very dangerous. They contain trans fats and they contain saturated fats. Use non-stick cookware, reduce the portion size. What is portion size? Portion size means if you ask for a masala dosha, it will be such a big one will come. So if three people are sitting, each one of you take one third, one third. That is the portion size. You want to have a cup of coffee, don't take a big coffee mug like your Starbucks mug or something like that. Have around 100, 120 ml of coffee only you have to take. This is what is called the portion size. In pizzas also, instead of ordering around 20 inches pizza or 15 inches pizza, order a 6 inches pizza and then take a small pie of that. So this is called the portion size. Fresh vegetables and raw vegetables must be used every day. Fresh fruits and vegetables. They are a must. How much? 5 servings of fruits in the morning, 5 servings in the evening, 5 in the night. Fruits and vegetables. Cut vegetables and fruits mixed together. 1 serving is 1 fistful. Like that, I have to have in 3 times a day. Don't eat fried snacks like chips, savory sweets. They're very tantalizing. If you open a chips packet, you will not be able to stop until the packet is completed. So this is the problem. We don't restrict like that. Likewise, sweets also don't gift or get sweets for yourself. And if the sweets are there, if you want to taste it, just have one sweet, make it into 4 pieces, take one small piece, and then eat it and enjoy the taste. You don't have to gulp the whole box to enjoy the sweet. Now, high glycemic foods. What are high glycemic foods and what are low glycemic foods? Glycemic index is the ability of a food to raise the blood sugar compared to 100 grams of glucose. Okay? If I give 100 grams of glucose orally, what will be the raise in the blood sugar? Compared to that, what will be the raise in the sugar value after consuming a particular food? If it is almost like, plain glucose, it is a high glycemic index. Low glycemic index foods they have fiber. So they don't raise the blood sugar very much even after taking them, and they slowly raise the blood sugar. With the result, the spikes and peaks of the blood sugar are avoided, which produce a lot of strain on the insulin axis. So for the insulin secretion. Now, there is what is called the DASH diet. Diet alone in systolic hypertension. There is one study called the diet alone in systolic hypertension, also called the DASH study. The DASH diet is whole grain 6 per day, say 1600 calories, but we don't require 1600. Being sedentary and low BMI, low body mass index people, 1200 kilocalories will be sufficient. In that, they use 1600 because they are all Western people. Vegetables, 3 servings, and then the 6 servings of grains, fruits, 4 servings, low fat milk, 2 servings, lean meat poultry, 3 per day, and the nuts and seeds, only not 3 servings, 3 per week, and then fats and oils, 2 servings, sweets and pastries, none, salted table and salted foods, none. This was called the DASH diet. This proved to be very good in reducing the blood pressure to around 10 to 15 millimeters from the baseline. Diet alone without any drug intervention. So today, the moment you see a hypertensive patient, two or three drugs straight away you prescribe. You don't stress on the importance of the diet, particularly the DASH diet. So this is called the food pyramid given by WHO. Okay, the food pyramid is there. 1 second. So the food pyramid you can see uh, white rice, white bread, potatoes, pastas, and sweets used very sparingly. This part. Dairy or calcium supplement 1 to 2 servings, where in this is the limited thing. Fish, poultry, eggs at 1 to 2 servings. Nuts and legumes all around the 3 servings. Vegetables in abundance. Fruits minimum 2 to 3 servings. Vegetables in abundance. Whole grain foods like whole grain bread, whole grain atta and other things. Canola oil, soya oil, and these are the olive oil, corn oil, sunflower oil, peanut oil, other vegetable oils, plant oils are important. Avoid the animal fats and animal oils. So this is about the daily exercise and weight also to be combined with the food pyramid. This is prepared by the WHO. WHO alternate food pyramid.gov. If you type, you can see the food pyramid here. Now, you can see vegetarian food. This is about the non-vegetarian food pyramid. Similarly, for vegetarians also, sweets and this one very sparingly. Milk, yogurt, cheese, these groups, dry beans, nuts, seeds, eggs, meat and substitutes. Instead of having meat, the meat substitutes like soy meat or soy protein, and then the green vegetables and all vegetables. The more colorful the food, the more healthy it is. Anything white, like maida, ghee, rice, these are dangerous foods. Bread, cereal, rice, pasta group are to be used very carefully depending on the type of this one. So this is a colorful basket of vegetables. So you have to have cut vegetables and fruits which are very colorful. Because all these colors are antioxidants. The more the colorful is the food, the more antioxidants are there in the food. Okay, so how do I go about implementing it? Fruits and vegetables. Fruit sugars are comparatively safe because they are pentoses compared to the hexoses which we take. Fruit pulp is to be eaten. Don't throw away most part of the fruit. Some fruits, of course, you have to de-skin them and use them. Not canned for fruits and juices. Do not buy canned juices and fruits because they contain preservatives and they have high calorific value. Avoid coffee and chocolate. Gift fruits and not sweets. Offer fruits only as courtesy if somebody comes to the home. Don't offer them coffee or any other unhealthy foods. Eat fresh and cut vegetables. Snack on the fruits and nuts in the afternoon. At coffee time, you would like to eat something. If you want to have 2 or 3 nuts, you can have and or on fruits. Do not ever overcook the vegetarian food. So what happens is in India, we have the habit of overcooking the food. If you overcook, what will happen? All the nutrients in the food are lost, particularly the water soluble vitamins. Reduce the simple carbohydrates like sugars and cane sugar and any sugar substitute. Some people will ask, is jaggery better than sugar? Both are sisters. One is elder sister, the other is younger sister. That's all. Jaggery is as bad as the regular sugar because this is a sugar is a sucrose. This is a disaccharide. It contains two sugars. They are very easily broken down. Fruits give lot of potassium. Potassium is healthier for blood vessel. If you substitute potassium for sodium in the diet, it saves the hypertension development and treatment also will become simple. Use soups and then buttermilk. Buttermilk as a courtesy. We have forgotten. Anybody comes or we meet a friend, no, should we have a cup of coffee? What cup? They will give you that much Starbucks, which you cannot finish in 2 hours. So that is like we are taking. Now, let us see type of food, fat in the food. What fats I should take? Saturated fats, SAFA. If you eat saturated fats, SAFA, SAFA. They increase the LDL, they increase the triglyceride, they increase the LDL receptor exposition. So saturated fats not only increase the LDL, they increase the LDL receptor population. So much so whatever little LDL is there is absorbed and then taken into the subendothelium, which produces vascular havoc. Butter, ghee, palm oil, beef oil, coconut oil, or any of these are saturated fats. Kerala we use lot of coconut oil. Coconut oil is a saturated fat, which we should not use. So how do you know in winter its melting temperature is so low that you can see in the winter in bottles the coconut oil is already solid. So these are very important. When we go to Southeast Asian countries, we cannot get anything cooked in other oils except beef oil. They will say vegetarian rice, but if you look at the rice, it is a beef oil. So beef oil is such commonly used there, which is a saturated fat. Unsaturated fatty acids, UFA. There are two types of unsaturated fatty acids. Monounsaturated fatty acids, MUFA, polyunsaturated fatty acids, PUFA, not FUFA, PUFA. MUFA and PUFA. MUFA decreases the LDL, decreases the triglyceride, HDL, A, and amino acids. And then olive oil, sunflower oil, safflower oil, canola oil, groundnut oil are MUFAs, refined groundnut oil. Polyunsaturated fatty acids, PUFA, PUFA, they decrease the LDL, they decrease the plasma platelet aggregation, they decrease the inflammation. So this corn oil, sunflower oil, cottonseed oil, these contain fatty acid number 3 to 6 fatty acids. N-terminal fatty acids 3 to 6. So you have to have MUFA and PUFA combination. So two parts of MUFA and one part of PUFA you have to combine to have it. How do I do that? 2 kilos of MUFA and 1 kilo of PUFA purchased and mixed and taken. Or 1 week you use PUFA and then the next 2 weeks you use MUFA. Anyway, it's okay. Trans unsaturated fatty acids, also called trans fats or TRUFA. These increase the LDL, increase the SLDL, they decrease the HDL, and they decrease the some apolipoprotein also is reduced. Dalda, vanaspati, margarine, processed fried foods, deep fat cooking, repeat or use of oil, all these are trans fats. So should avoid what type of fat you eat is the step. ATP3 nutritional component of TLC. What is ATP3? Adult Treatment Panel 3. So Adult Treatment Panel 3 is a very wonderful study on the nutrition and then CM, cardiovascular risk. Saturated fat less than 7%, polyunsaturated fat up to 10, monounsaturated fat up to 20%. That means total 30% can be the fat, total fat 25 to 30%, carbohydrates not 50%. This is for people who are non-obese and non-diabetic. To reduce the cardiometabolic risk, you have to keep the carbohydrate to 35% and 35 to 40%. Fiber 30 to 40 grams. Protein should be at least 25% of your total calories. Total cholesterol consumed per day should be less than 200 milligrams because foods do contain cholesterol. Trans fatty acids also raise the LDL and should be kept at a low intake. Regarding total calories, balance energy intake and output. Suppose your elderly man is there, woman is there, not going for any work, not doing any physical activity, the energy expenditure is reduced. So much so an intake also should be matched with the expenditure. What you are eating in 30s and 40s with the high energy output cannot be the same food, cannot be used when you are elderly and old. At that time, the energy requirements are less, energy expenditure is less, energy input also should be reduced. So these are the fatty acids. This is the double bond. These double bonds tell you unsaturated fat. Mono unsaturated fatty acids means there is only one unsaturated double bond. Poly means many. Okay. Saturated fats means there is no unsaturated bond, double bond. Everything is saturated. These are dangerous. These are good. These are also essential. There is one other thing called the omega fatty acids. Omega fatty acids are short chain fatty acids, less than three carbon atoms. This is a long chain fatty acid. You can see so many carbon atoms. Omega fatty acids, they have less than three carbon atoms. So comparison of dietary fats, canola oil, MUFA, PUFA component, saturated is this part and monounsaturated is the green and polyunsaturated is this one. Canola oil, mostly monounsaturated. Safflower oil, mostly MUFA. Sunflower oil, mostly PUFA. Corn oil, mostly PUFA. Olive oil, very good MUFA. Soybean oil, it is mix of PUFA and MUFA. Peanut oil, more of MUFA, some amount of PUFA. Margarine, this also is hard margarine. So this is a lot of saturated fat is more in the margarine. As you go down, you can see in margarine, cottonseed oil, seed oil, lard, palm oil, fully saturated fat, most of it, beef tallow, beef oil, butter. Some say 60% is already saturated fat. Coconut oil, around 95% is saturated fat. We don't know that. We keep on using, thinking that it is very healthy for. They even argue. Go and ask anybody in Canada. No, no, no. Coconut oil is very, very good for health. We have been using for generations. That's why we are suffering the highest CAD rates, CHD rates among India. Kerala is one of the leading states of highest CAD rates. Tamil Nadu and Andhra compete with that, not because of fat usage. Tamil Nadu and Andhra, the rice usage. The rice is so much more in these two states, Andhra Pradesh and now present Telangana and Andhra. And Tamil Nadu, the rice eating is so much. And Kerala, the rice coupled with rice is staple diet there, along with the coconut oil. Okay. I'm not blaming any one population. I'm showing these are the variations in the diet that we have. Okay. So this is where we are. Okay. Now, you see the reduced intake of the trans fatty acids. So you can see based on the change in the total HDLC, based on replacement with carbohydrates, based on additional benefits of replacement with cis unsaturated fatty acids. You see here reduced by half. So near elimination. If you reduce the trans fats by half, you can see the change in the risk. And if you reduce by totally eliminate it, the drop in the risk is so profound that never use any trans fat. What are trans fats? I told you vanaspati, dalda, reboiling the oil, some of the oils used in the cooking for the shelf life, they'd use the trans fats. Fruits, vegetables, 3 to 5 servings of fruits, vegetables, more than 5 servings, but less than 3 servings. So you can see relative risk reduction, as you can see, so much risk reduction. So fruits and vegetables, if you eat more, definitely the risk is reduced. Approximate mortality reduction from pharmacotherapy and lifestyle diet. Low-dose aspirin reduces the risk by 18%, statins by 21%, beta blockers by 23%, AC inhibitors by 26%. All when compared to 100% by the diet and other lifestyle changes. So what is important? Lifestyle change is important. So CAD with high TLC and CAD, therapy, diet, exercise, meditation, diet and fiber, diet and exercise. Duration 1 to 3 years they have followed, and you can see the effect of lifestyle changes on angiographic CAD. There is a 40% reduction, there is a 38% reduction, there is a 15% reduction in the angiographically improved coronary artery disease. Obesity treatment issues. The goal reduction in the weight by at least 10 to 55 to 50%, 15 5 to 10% of the existing weight. Somebody is 80, they can reduce 8 kilos. Somebody is 100, maximum they can reduce by 10 kilos in 1 year. Time frame 6 months to 1 year. No quick fixes, no crash weight reduction programs. Sibutramine, Orlistat, Rimonabant are various drugs. Rimonabant is out now. We can't use. Sibutramine is also sparingly used. Orlistat is available. Genical. This prevents the carbohydrate absorption, gastric banding, and GI plasty, liposuction of the abdominal fat, and a Roux-en-Y type of gastric bypass. So many new surgical procedures have come. This is the bariatric surgery is also an option. CHD prevention strategies, smoking. So this is how. So if you keep smoking, the skull only will remain. There is no face here. So this is like making ourselves as nearer to the grave as possible. Okay. How to quit smoking? Ask, advise, assess, assist, arrange. This is the methodology. Ask whether they are smokers, advise, assess whether they are following, assist them, and arrange. Ask all patients about personal history of smoking, number of pack years, exposure to passive smoke. Ask at risk for visiting at each visit. They check for smoking status. Advice to quit must be clear and unambiguous. Be supportive. Remember, you are not the one quitting, they are the ones. So don't be judgmental. Offer resources and support consistent with the individual needs. Follow up at each visit. This is the advice. Then you have to assess. Assess the withdrawal, boredom, sense of deprivation, emotional upset and stress. They will replace with alcohol. One devil is replaced by another devil. Ask him to stop smoking. He stops smoking and converts to an alcoholic. That is no use. Reduction in the total personal exposure to tobacco smoke. Smoking cessation is the single most effective, cost-effective intervention in reducing COPD. See, smoking cessation is the single most effective intervention to reduce COPD. All other measures that you do for COPD have less efficacy. It is crucial for CAD prevention also. It is the cornerstone of peripheral arterial disease. So every smoker must be persuaded not to smoke. So in India, 50% of population, women population, generally they don't smoke. Remaining 50% people, the smoking rates are around 5 to 10% uppermost. That is, totally in 100, 5 to 10 smokers are there in India. 90 to 95% of people are non-smokers. These 95 people motivate those 5%. Totally the world will be without smoking. If you can convert one smoker into a non-smoker in your life, you have done a great job. If all of us can take the responsibility on us, being non-smokers, if you are a smoker, quit it. If you are a non-smoker, take the responsibility to convert at least one non-smoker into a non-smoker. That way, you can reduce the smoking burden. Then you also have the drug treatment for smoking. That is, bupropion, smoke with SR, Nicotex, several medicines are available. Psychological dependence on nicotine, useful in individuals with or at risk for depression, contraindicated in seizure disorder and drug interactions. So today we have got wonderful drugs which can help them in cutting the smoking. Helpful for physical withdrawal symptoms, can be dosed according to the degree of use, cost the same as daily smoking habit. Most produce the nicotine replacement therapy. Most products are NRT, nicotine replacement therapy. So these are some of the smoking cessation guidelines. CHD prevention, are there any medications? So what did we do? We went to the total lifestyle control. Under that, we talked about the calories. We talked about the fats. We talked about fiber and protein intake to be more. We also talked about glycemic index and complex carbohydrates. We talked about the exercise, physical activity, that is fit, frequency, intensity, and time duration. Then most important, the devil, the smoking part we said. We also talked about trans fats and then MUFAS and PUFAS and what combination we have to take, why to avoid saturated fats. Then we are now coming to the medications. So American Heart Association evidence-based guidelines, key strategies for high-risk patients. If the 10-year coronary artery disease risk in Framingham scoring is more than 20%, we have to institute this. All of us should get the Framingham risk score for every patient. Very easy. You just type in the Google Framingham risk calculator. Calculator will come. In that it will ask what is the age, gender, smoking, diabetes, hypertension, present treatment, all the variables, you have HDL, LDL, you feed into that. The next summary risk score will come. That risk score, 10-year risk score should be less than 10%. If it is more than 20%, you have to put them on this treatment. Did you ever do any risk scoring for any patient? Diabetes, no, you have to control sugar. The BP, you have to take BP tablet. That's not all. You have to make a risk assessment properly, guide them with all the factors. Physical activity, cardiac rehabilitation, smoking cessation, diet as a treatment, weight maintenance, BMI maintenance, waist maintenance, BP, lipid control, statin treatment, and then aspirin, beta blocker, ACE inhibitor, glycemic control. There are 4 ACEs. ACE1 is aspirin, ACE2 is ACE inhibitor, ACE3 is atorvastatin, ACE4 is A1C control. I'm repeating. You have to serve all the 4 ACEs for vascular protection. VP, vascular protection. ACE1, aspirin as a primary prevention. Not when disease comes. ACE inhibitor, irrespective of the blood pressure. Glycemic control, A1C control, and then statin, irrespective of the cholesterol. The high-risk patient should receive statin irrespective of the cholesterol value. ACE inhibitor, small doses, Tamiflu 2.5, or you can use ARB like your 20 milligrams of any one of the ARBs. You can use these things, Telma or any of those things. 20 milligrams as a base dose for reducing the coronary artery disease. Glycemic control should be attained. It should be maintained less than 7, preferably less than 6.5. No routine hormone replacement therapy for women unless it is really required. Because HRT, estrogen, is supposed to increase the endothelial dysfunction and coronary risk status. So we should not put unnecessarily on estrogen replacement therapy. CHD prevention strategies. Primary prevention of CHD. What is primary prevention? Disease has not developed. There is no evidence of vascular, cardiovascular, coronary artery, peripheral arterial, cerebrovascular, renovascular disease as yet in this patient. But patient is loaded with the risk factors which we have discussed during the last 2 lectures. Then what I have to do? Hypertension control, A, B, D. Hypertension should be controlled properly. A is aspirin, B is beta blocker, D is diuretic. Aspirin should be given to all hypertensives, 75 milligrams to 100 milligrams. 150 may not use, 75 to 100. Exercise and weight reduction, smoking cessation, statin must be prescribed. Small dose of atorvastatin, minimum 10 milligrams. If you want to use rosuvastatin, 5 milligrams as the primary prevention dose. Estrogen therapy has no benefit in the primary prevention of CHD. Estrogen replacement therapy has no benefit. So control of hypertension, aspirin 75 milligrams, exercise, weight reduction, smoking cessation, 10 milligrams of atorvastatin or 5 milligrams of rosuvastatin for primary prevention. Means none of the cardiovascular diseases have yet come out in a overt manner clearly to demonstrate, but all the risk factors are there. Age also. Primary prevention. Age is anybody more than 70 years. Primary prevention is essential. If they are hypertensive, control hypertension. Little statin, for example, everybody above 70, irrespective of risk factors, they must get a small dose of statin. Aspirin above 70 is not advised. Unless there is a secondary prevention, tertiary prevention, yes. For primary prevention, earlier 20 years back, we were teaching them to give aspirin. Now studies have shown that you should not use aspirin in the elderly for risk of cerebrovascular and other GI bleed and other. Aspirin you hold unless there is an indication, secondary prevention and tertiary prevention. As aspirin as a tool for primary prevention in the elderly is not available now. Don't prescribe. Secondary prevention, hypertension control, beta blockers reduce the demand, aspirin 75 milligrams, ACE inhibitor is mother's milk for 2.5 milligrams of ramipril or 5 milligrams of enalapril you have to use. ARBs, telmisartan or olmesartan, you have to use 20 milligrams. Aggressive statin therapy, here not 5 milligrams of rosuvastatin. You have to use 20 milligrams of atorvastatin or 10 milligrams of rosuvastatin. PTCA, CABG preventively, smoking cessation, exercise rehabilitation. These are for the secondary prevention. The lowest effective dose of aspirin in primary prevention is less than more than 50 years, 160, more than 50 years women 100, stroke in men 160, stroke in women 100, stroke in men and women with atrial fibrillation, you must give at least 375. I told you for 70 years and above, we don't use it in primary prevention. Secondary prevention, MI with hypertension and stable CID. Okay, 75 milligrams. MI with history of AMI 160, stroke with TIA 50 milligrams, stroke without acute stroke 160. So depending on the patient's need, we have to increase or decrease the aspirin. Secondary prevention CAD, you see, none. If you don't give any of these preventers, then 2-year event rate is 8%. 2 years, 8% of them will develop a coronary event. If you give aspirin from 25% to 6%, you can reduce. Beta blocker, 4.5%. Lipid lowering therapy, 3%. ACE inhibitors, 2.3%. All four therapies together can produce 75%. Aspirin alone reduces 25. This is the relative risk reduction. This is the 2-year CVD reduction. Aspirin alone 25 combined with beta blocker, another 25, 30%, 25%. ACE inhibitors, 75%. All four therapies plus smoking cessation, relative risk reduction is 80%. Very important. Yusuf et al. Have published this in Lancet from McMaster, Canada, where I studied. Okay, control of diabetes. Type 2 diabetes and coronary artery disease are two diseases in the same disease in two varieties, two disguises. CAD equivalent is type 2 diabetes. PVD is more common in type 2 diabetes. It equalizes the gender difference. Suppose a woman before 50 years develops diabetes, she becomes a man, has risk as a man. FPG and PPG control, diet and exercise and medicines are important. When does a woman become a man? A woman has got same risk as men if she develops diabetes before 50, if she is a smoker, and if her BMI is more, if her waist is more. Weigh or smoker. Smoker, BMI, waist, and then age beyond 50, and then developing diabetes. All these things will make women and as bad as men before 50 years. A1C must be kept below 7, preferably 6.5. BP target 130 by 80. 10 millimeters better to be lower for for the diabetic people. 130/80 for non-diabetics. For diabetics, 120/70. Must get statin even if the lipids are normal. Aggressive control of the dyslipidemia, ACE are a must. Beta blockers if there is no peripheral vascular disease. Oral agents, metformin, sulfonylureas, azoridins, repaglinide, acarbose, meglitol. You have so many newer drugs which we can use. Insulins, conventional analogs, latest exenatide, GLP-1 analog, dual PPRs, amylin. So many things are there. DPP, Diabetes Prevention Program, placebo, metformin, lifestyle. They have three arms. One group of patients received nothing, they received placebo. Another group received only lifestyle advice. The third group received metformin. The results are diabetes incidence is by placebo. The diabetes incidence is 11% in the next 5 years. Okay, here 7.58% it was brought down by lifestyle was 4.8. So everybody should be submitted for lifestyle intervention to reduce the risk of diabetes. Okay, secondary prevention, CHD risk reduction in patients who are forest subgroup of patients with diabetes. Now, forest study is simvastatin study. Placebo better, none. In no case, placebo was better. Simvastatin is better in all the studies in terms of total mortality, CHD mortality, major CHD coronary artery disease events, any event, CABG, PTCA, cerebrovascular event, any atherosclerotic event. For all of them, simvastatin fared better. There are two lines, white and yellow. In the diabetics, the profound difference is there compared to non-diabetics. So every diabetic and every cardiometabolic patient must receive a statin. Okay, control of hypertension. So hypertension is a strong risk factor in isolated systolic hypertension, more important than the diastolic. Salt restriction less than 2 grams per day. What is 2 grams of salt? Suppose in a month we have 30 days. 30 into 2 is 60 grams of sodium. And then let's say a family of 4 people are there. 60 into 4, 240 grams of sodium only to be purchased. If you purchase more, the kidney has to excrete all that. This is called the tax deduction at source. You can cut off the intake of sodium even at the level of purchasing. Diet low in saturated fats, treatment of dyslipidemia, goal blood pressure, at least 10 millimeters less for diabetics, ACE/ARBs, beta blockers, thiazides. These are three important three groups of drugs. For at least 2 drugs should be used for hypertension. Isolated systolic hypertension. Indapamide is useful. Calcium channel blockers and beta blockers. Otherwise, in general, calcium channel blockers are not the first line of drugs unless you use a newer generation calcium channel blockers. Target organ damage, you must assess LVH, ABI, pulse pressure, brachial flow meter dilatation in all cases of hypertension. LVH is the single most important predictor in hypertension. Control of dyslipidemia. Clinical benefits of cholesterol reduction, CHD mortality reduced by 15%, total mortality by 11%. Meta-analysis of 38 trials demonstrated that for every 10% reduction in total cholesterol, CHD has reduced by 15%. Decreases were similar for all treatment modalities. Cholesterol reduction did not increase non-CHD mortality. You can see atorvastatin, how much risk reduction, dose 10 mg, 20 mg, 40 mg, 54 mg. Not much of improvement after the 10 mg. 10 mg of atorvastatin as prevention is important. And simvastatin 28, 35 and 40. Diary dose, this is the diary dose. So what does it mean? LDL cholesterol clearing is a very important risk reduction strategy. HCTMAB Ezetimibe is a drug which prevents the absorption of the cholesterol along with atorvastatin. If you use ezetimibe and atorvastatin combination, this is the risk reduction compared to increasing the dose of atorvastatin. It is 80 mg atorvastatin is equal to 10 mg ezetimibe and 10 mg atorvastatin. So better, that is 10 plus 10 is equal to 80 study. In this study, they demonstrated atorvastatin 80 milligrams used produced a similar reduction as the ezetimibe 10 plus atorvastatin. Okay. Post CABG study, aggressive versus moderate treatment. So somebody is put on aggressive lipid treatment, but the LDL cholesterol is brought to less than 100. They fared very much better in terms of the disease burden and survival compared to those who had moderate treatment where the cholesterol is left around 135 LDL cholesterol. The risk was more. You should always try to get the LDL cholesterol below that cutoff point or 100. Anybody who is having more than 100, don't say, no, no, it's 130, no problem. Don't say like that. Bring from 130 to less than 100 by vigorous treatment. Non-pharmacological approaches, lifestyle modifications, diet, alcohol restriction, maintain ideal body weight, exercise, and smoking cessation. Okay, now newer treatments, selective LDL apophysis is there, and then you have the ApoA1, melano recombinant HDL, ECB1 receptor, rimonabant weight loss, dual alpha gamma PPR activators, peroxisome proliferative receptors, activation receptor, peroxisome proliferative activation receptor, PPR gamma and PPR alpha, muraglitazole, and then saraglitazole. So many drugs are there. CETP inhibitor, torcetrapib also is there. The three canons, dyslipidemia, LDL or statin, if it is increased or normal also, for prevention, statin should be given. TG, fenofibrate, HDLC, niacin, all three have to be used. Lipid abnormality, LDL more, statin, TG more, fibrate, LDL low, niacin, LDL and TG more, statin plus fibrate, and then LDL, TG more and HDL, statin plus fibrate, or statin plus niacin can be the combination. Lipid abnormality, advised treatment. Homocysteine, if it is a risk factor, is more than what we thought, folic acid, B6 and B12, small and dense LDL, statin and fibrate, little a, LPA, niacin, phenotype B, we don't have any direct drug as on date. Control of diabetes and obesity can modify the phenotype B. Phenotype A, aerobic exercises. If the phenotype A is less, then you can increase the aerobic exercise. Now, some of the brand names which you may not require. Take home messages. How do I prevent coronary artery disease or cardiovascular risk management? We have discussed at length for 3 classes what are the various risk factors and how do we manage the risk. So these are the final take home messages. Non-modifiable age, gender, ethnicity. Indians are notoriously having higher propensity, family history of coronary artery disease, personality, phenotype. So type A personality is dangerous, type B is suitable. So these are the non-modifiable risk factors. Modifiable, diabetes, hypertension, smoking, lipid abnormalities, obesity, waste, physically inactive. This you have to tackle. Then the emerging risk factors, endothelial dysfunction, lipid lipoprotein small a, SLDL, hsCRP, ApoA1 by B, and then homocysteines. These have to be treated. So hsCRP, statin, SLDL, statin plus fibrate, LPA, niacin, endothelial dysfunction by controlling all these factors, homocysteine by folic acid. You have to use the folic acid. This is the total risk summary. Now, the Saptapadi are the 7 steps. What I should do? What are the 7? Screen, define, and target high-risk patients. modify lifestyle factors like MNT, medical nutrition therapy, and physical activity. Explain and persuade to quit smoking and decrease the alcohol. Aspirin 75 milligrams in all those with at least one risk factor. Tell me a person who does not have one risk factor. That means aspirin must be given to everyone. Aggressive control of diabetes, HbA1c less than 7. Attain BP goal 10 millimeters less than this 140/90. So 3130 by 180. And diabetics further 10 millimeters less. ACE inhibitors and statin for all diabetics. Statin for ACE inhibitors and statin for all diabetics. Statin for LDL increase, address HDL, LPA, triglyceride, HCRP if they are abnormal. Now, forget not, total lifestyle control is essential to keep the ideal weight. Drugs are inevitable to control the risk factors. Patients say, no, 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 I will try diet, I will try yoga, I will try meditation, I will try Kriya Yoga, I will reduce. No, no, no. You have to start on the risk modification with the drug. They're inevitable. Role of stress and avoidance, if it cannot be overemphasized. Yoga, relaxation, meditation, music, family outings, tourism, reading books, socialization are essential. Avoiding the idiot box, that is the TV. And now today, TV is replaced by mobile phone and the laptop that will help the body as well as the mind. Okay. Shun negative behavior, worry, fault finding, and then anger, vengeance. These are all Arishad Vargas, the six internal force, blaming others, lust, greed, jealousy. You need not say about those six internal force. Kama, Krodha, Lobha, Moha, Mada, Matsaryas. These are the six internal enemies. They must go. Anxiety and depression must be avoided. All increase the HSCRP, interleukin 6, and endothelial dysfunction. They are not for becoming saint. They are to keep you healthy, reducing these fluctuations of mind, the passion and dispassion. Passion, that is raga, aversion, dvesha. Like that, all these duels to keep them in check, not only for the mind, but also for the body also. This pave a perfect way for CAD to set in. Once you have HSCRP more, interleukin 6 more, endothelial dysfunction is triggered, that will very soon get a coronary artery disease. So metabolic patient is there. How many pills? Glimepiride and metformin he has to take. Pioglitazone or any other drug he has to take. Nitrate long-acting, 2 tablets. Aspirin clopidogrel combination, 1 tablet. Statin, 1 tablet. Fibrate niacin, 1. Ramipril hydrochlorothiazide combined, 1. Carvedilol metoprolol beta blocker, 2 tablets. 2 times he has to take. Other supportive medication. So total 12 tablets he has to take. The minimum rupees probably is now 200. This was calculated long back. So 200 rupees per day. In 30 days, he requires 6,000 rupees just to maintain the disease status quiet. If wife and husband are there, then there will be 12,000 rupees. How many people can afford? Huh? So what I can do? I can reduce the number of tablets by tackling the risk factors in the first go so that they don't have to be taking medicines forever. Okay. Now, most important thing is for each ill, at least one pill we are giving, and that's to be reduced by controlling the risk factors. At what cost one suffers? 50 rupees in those days, let's say it is 200 rupees into 30. Age 40 to 65 years, 25 years, you take the medicines, more than 15 lakhs, 20 lakhs. Cost of CABG, minimum 2 lakhs in those days, nowadays 5 lakhs. What about the cost of consultations and tests? What about the comorbidities like osteoarthritis, cataract? What about the intercurrent illnesses and admissions and pneumonias and treat diarrheas? What about the treatment of heart failure, renal failure, peripheral vascular disease, laser treatment for the eye? No third party payer. You have to spend by ourselves. Most of the people in India, they have to spend from their pocket. What is the value of all this prolonged suffering? Leave alone the money part. Suffering with coronary artery disease or cardiovascular ill health is a great suffering which has got no dollar value. Okay? Hippocrates, long back, he said, let your food be your medicine. That means eat food as you eat medicine in a limited way, lest if not, your medicines will replace your food. That means you have to eat medicines in the plate as breakfast, medicines plateful in the afternoon, again in the night. If you let your food be medicine, otherwise your medicines will replace your food. This is what is the truth. So where are we heading? So 20,000 BC, the hunter-gatherer. 2016 today, in the 21st century, hunter-gatherer man, high level of physical activity, have come to processed foods, animal fats, glucides and other dietary fibers. Sedentary lifestyle, always sitting before a computer or a TV. And coupled with that susceptible genotype. This has converted a very healthy Homo erectus sapiens into a cardiometabolic man. Okay, technology has changed a lot, but we have not altered our lifestyle. Okay, we have to pay a very heavy price. What could be prevented? We treat or leave untreated. Should we not address this early in 20s and 30s? Should we wait till we suffer and succumb? Is it not cost effective and safe to take action now? What for are we waiting? Whose permission is required? Who will bell the cat to motivate the CAD prevention? It will never be a priority for our governments. They will be having several priorities, but preventing cardiovascular risk is not their priority. It is we, the answerable ones, should take steps. Take a pledge now to screen all above 30. Initiate them into preventive action, persuade and persist. Diabetes and heart disease, American Diabetic Association, diabetes is directly linked to heart disease and stroke. That is what this slide says. Diabetes is coronary artery disease in motion, same only. Okay. So this girl is praying for, dear God, let my miracle happen. Please save my mom. Please save my dad. She's praying. When everything is burnt, what is the use of praying God when we have not taken care of the things? This poor girl will lose the parent with heart attack or stroke. Then she will become an orphan. And you can imagine her life, future life, how bad it is. Let this not happen. Okay. Thus we end the cardiovascular risk presentation, and three is including the prevention and strategies and some baseline guidelines of treatment. So any questions you have, you can